Bismillah ar-Rahman ar-Rahim. Today we'll talk about treatment of epilepsy in adults. My name is Khalid Al-Qadi. I'm a neurologist and epileptologist at King Faisal Specialist Hospital and Research Center in Jeddah. So the points to cover in this lecture are the following. So we'll go over the anti-epileptic medications, and we'll talk about the commonly used anti-epileptic medication in Saudi Arabia. We'll go over the definition of epilepsy, when do you start anti-epileptic medications, and when do you stop anti-epileptic medications. Also, we'll talk a little bit about anti-epileptic medications in elderly, and then at the end we'll just go over other treatments in epilepsy. So anti-epileptic medications overview. So we have more than 25 anti-epileptic medications now available to use, and these can be divided into 3 generations. The first generation, the anti-epileptic medications that were described before 1990s, and these the old anti-epileptic medications, including and some of them still are being used, including phenytoin, phenobarbital, valproic acid, and some actually of the benzodiazepines, primidone, and others. Between 1990s till the 2000s, we have what's called second generation anti-epileptic medications, and these include fulvamate, gabapentin, lamotrigine, levetiracetam, oxcarbazepine, pregabalin, topiramate, and others. And then later on, from 2000s till now, a few anti-epileptic medications came to the market. For example, vegapatrin, rofenamide, lacosamide, clobazam, which is another benzodiazepines, eslicarbazepine, and recently eslicarbazepine and perampanel. So we can divide the anti-epileptic medications based on the mechanism of action. If we talk about the fast sodium channel blockade, and this is, I think, is the most common mechanism of action for most of the anti-epileptic medications, and that include old as well as new anti-epileptic medications like phenytoin, carbamazepine, oxcarbazepine, lamotrigine, eslicarbazepines, and others, as you see in the table. Also, there is a slow sodium channel blockade, such as, or actually the only medication that works in this is lacosamide. We have 2 types of calcium channel blockade, type T is a valproic acid, ethosuximide, zonisamide, and type alpha 2 delta gabapentin and pregabalin. The second most common mechanism of action is GABA enhancing, and that includes all benzodiazepines, valproic acid, phenobarbital, vegapatrin, fulvamate, and others. Also, glutamate receptors antagonists are being used, such as lamotrigine, topiramate, fulvamate, and perampanel. And ezogabine works as actually a potassium channel blockade. And then 2 carbonic anhydrase inhibitors are being used, topiramate and zonisamide. Keep in mind that some of the anti-epileptic medications have multiple mechanisms of actions. As in here, you see the topiramate that works as a glutamate antagonist as well as carbonic anhydrase inhibitors, and it works also in the fast sodium channels. And that's also the case for valproic acid, as you see in the table. So we talked about mechanism of action and different receptors, but then the mechanism of action actually has almost no clinical impact or physiological correlation when you choose the anti-epileptic medications in most of the time, except if you have a sodium channel defect, and then we don't recommend to put the patient on sodium channel blockade. such as the Dravet syndrome. And then many neurologists or epileptologists use different mechanisms of action if a polytherapy is needed, which actually makes sense more than has a scientific background. Then the antiepileptic medications, especially the old antiepileptic medications or the first generation antiepileptic medications, work on the cytochrome P450. And then this includes broad spectrum inducers or selective inducers. And you see in this slide the broad spectrum inducers include phenobarbital, brimidone, phenytoin, carbamazepine, which is, they all actually work as inducers acting on multiple levels of the P450 system. And then the selective ones include oxacarbazepine, topiramate, usually at higher doses, and felbamate. Clinical impact. So we talked about the inducers and the P450 system, but what's the clinical impact and why we should worry about this? If you look at this table, and this is the list of the medication that increase the serum concentration of antiepileptic medications, so it's a sort of interaction. If you look, for example, at the carbamazepine, the carbamazepine level can be increased by a lot of medications, including antiepileptic medications such as valproic acid and antidepressant and even antibiotics. Also, that's the case also for ethosuximide, lamotrigine, phenobarbital, valproic acid, and phenytoin, which also the level of the phenytoin can be increased by many medications, including antiepileptic medications, antidepressants, antibiotic, and other agents. So to simplify this, so at this table we talk about which antiepileptic medication you should use. So it depends on the type of epilepsy, and that's divided by partial versus generalized epilepsy. And for the partial, that includes simple partial, complex, with without secondary generalization. And the list here is big, and the one I highlighted is the ones that we use in Saudi Arabia and available in the Arab countries, such as phenytoin, carbamazepine, oxacarbazepine, pregabalin, lacosamide, and others. And then for the generalized type, we have the ethosuximide, which works on absence seizures, and other medication that we can consider as a broad spectrum that works for all generalized epilepsy as well partial epilepsy, partial onset epilepsy, and that include valproate, lamotrigine, topiramate, and levetiracetam. So now we'll talk about the monotherapies versus polytherapy, and we'll talk about each type of epilepsy. So for the best evidence we have in patients with partial onset seizures, the best evidence for antiepileptic medications include carbamazepine, oxacarbazepine, phenytoin, topiramate, and lacosamide, and other effective medication that we know it works. Maybe we don't have the great evidence. We have some evidence, but not great evidence. But we know for sure it works as a monotherapy for partial seizures. That includes lamotrigine, gabapentin, levetiracetam, eslicarbazepine, valproate, and others. Also commonly used without good evidence is zonisamide and pregabalin. And now, monotherapy for generalized epilepsy, the best evidence we have is for topiramate, valproic acid, and levetiracetam. Other effective antiepileptic medications that we know that they work, but maybe we don't have that great evidence to support that, including zonisamide, clonazepam, clobazam, and others. Keep in mind that some anti-epileptic medications like phenytoin and carbamazepine actually may exacerbate some types of generalized epilepsy like myoclonic epilepsy or absence seizures. And lamotrigine may exacerbate the myoclonic seizures of symptomatic generalized epilepsy. So for absence seizures, we have the best evidence for two medications. ethosuxamide, which has a limited spectrum. It works only for absence seizures. And then valproate, which is more broad spectrum antiepileptic medication. Other effective antiepileptic medication includes lamotrigine, zonisamide, levetiracetam, topiramate, fulminate, clonazepam, and clobazam. But we know for absence seizures, the best evidence supports ethosuxamide and valproate, and both medications should be a first line in this condition. For myoclonic seizures, which is again type of generalized epilepsy, the best evidence is for valproate, levetiracetam, and clonazepam, and other benzodiazepines. But and other medication that we think that actually also helpful in this condition include zonisamide and topiramate. Let's talk about seizure aggravators. As we said before, some antiepileptic medications may exacerbate seizures if they're used inappropriately. And that includes the medication that used for only partial onset seizures when they're used for primary generalized or recently changed to genetic epilepsies, such as gabapentin, pregabalin, carbamazepine, oxcarbazepine, tiagabine, and phenytoin. So when you use these medications and the patient gets worse, then think about the diagnosis. They might have actually primary generalized or genetic epilepsy. And then the newer ones like lacosamide, islecarbazepine, and others, we don't have that great evidence or data to support the use or not to use them in generalized genetic epilepsy. What about in acute settings? So in acute settings, in patients with status epilepticus, when you need really to titrate the medication really fast, then the options are limited actually. You can use only the IV forms, which are available for phenytoin or fosphenytoin, which is a type of phenytoin or similar to phenytoin, and phenobarbital, valproate, levetiracetam, and lacosamide. But then sometimes you can rapidly increase the dose for oral medications, and that's the case for phenytoin, carbamazepine, valproate, oxcarbazepine, and levetiracetam. Now we'll talk about more details about the commonly used anti-epileptic medications in the Arab countries, especially in Saudi Arabia, what were the available anti-epileptic medications that we use on a daily basis. And we start with one of the oldest medications, phenytoin. The absorption rate for phenytoin is about 95%. It has a protein binding about 90% of the phenytoin, and then metabolized by the liver. The problem with the phenytoin is the interactions. Interacts with a lot of anti-epileptic medications, other antibiotics, coumadin or warfarin as anticoagulants, and also interacts with the and actually it works in it binds to the protein, so it interacts with the other medication that binds to protein as well. In terms of side effects, so the acute and idiosyncratic side effects including allergy, rash, fever, hepatitis, serum sickness, and the long-term ones including gum hypertrophy, hirsutism, macrocytosis, leukopenia, osteoporosis, ataxia, and even drug lupus. So it has a lot of interactions, and the side effects profile is not that good. On top of that, phenytoin has a unique kinetic order. So it has what's called zero kinetic order or non-linear kinetic order. So when you give the phenytoin to a patient, or when you give any medication to a patient, usually once you increase the dose, the level increase on a linear relation. But in phenytoin, it's actually not the case. At some point, usually around 300 milligrams per day or 400 milligrams per day, you reach the level that after that, when you increase the medication, the level shoots up. So that's called the zero kinetic order. So when you give the medication, you increase only by 50 or 100 milligram per day, the level may actually shoot up to and causes toxicity. And that's as you see in the figure, in this figure. Also, phenytoin in elderly is not really favorable. Why? Because of this study that shows different phenytoin level in nursing home residents without changing the dose. So it's because of the absorption, because of the interaction with other medications, the level of the phenytoin differs every time you check it. And that's what you see here in elderly patients when they divided them into 3 groups between age of 65 to 74, 75 to 84, and above 85. And most patients actually will have different levels without changing the medication or the dose. The next one is carbamazepine, which is also an old antiepileptic medications, absorbed about 85% of the time with a protein binding 75%, also metabolized by the liver, and it has a unique feature, what we called autoinduction. So typically when you give carbamazepine after a few weeks, 4 or 6 weeks, the liver actually creates receptors that causes autoinduction, so that increase the metabolism of the medication. So most of the time you need to increase the dose at that time. It also interacts with a lot of medications, and the side effects profile is not also that great. It can cause nausea, vomiting, rash, hepatitis, aplastic anemia. Also, hyponatremia is of a great concern in these medications, as well as neutropenia. Valproic acid. Valproic acid also considered an old antiepileptic medication with absorption of about 100%, and then protein binding in 70 to even 95 or so percent. Also metabolized by the liver, interacts with a lot of medications, including antiepileptic medications and others, and with a side effects profile also not that great. Acutely, you can see acute liver failure, and that's of a concern, especially in children less than age of 2 years, and may cause actually even pancreatitis. On long term can cause encephalopathy, GI upset, hyperammonemia, thrombocytopenia, and hair loss, as well as tremors. It also has a teratogenicity effect, the highest of all antiepileptic medications. In a monotherapy, about 6%, and goes above 10% if you use other antiepileptic medication, or what we call polytherapy. Also, we also now know that the offspring may have actually some cognitive impairment with the low IQ. Benzodiazepines, commonly used here in Saudi Arabia, clonazepam and clobazam, with absorption of about 90%, protein binding about 80%, and metabolized again by the liver and enhanced, so the level decreases by enzyme inducers, with a side effects profile of respiratory depression, paradoxical effects, so patients get worse when you give them the benzodiazepines, and tolerance. So after time you need to increase the dose because the patient, the medication is not working anymore as the patient developed the tolerance or became tolerant to the medication. Be careful when you stop benzodiazepines, because the withdrawal symptoms can lead to seizures and anxiety and tremor, which is not uncommon. So we see it. You have to taper off the dose slowly if you want to stop the medications, not to stop it appropriately or abruptly. Lamotrigine is also, the absorption for lamotrigine is about 90% or so, with a protein binding 55%. It has both hepatic and renal metabolism, interacts with other antiepileptic medications, namely valproic acid. So the level of lamotrigine increases by concomitant use of valproic acids, but the level of lamotrigine decreases by the use of oral contraceptives. So keep in mind when you're using these medications, if the patient is taking valproic acid or this is a female patient who's taking oral contraceptives. It also has synergetic and additive interactions with valproic acid. So the valproic acid increases the lamotrigine level and vice versa. Also, they increase the effectiveness of each other. Side effects of lamotrigine, you have to titrate this medication very slowly over weeks, usually 6 weeks or so, because if you give the medications on high dose initially, there is a high chance of having a rash, which is about 7 to 10%. But if you give it slowly over 6 to 8 weeks, this chance decreases to less than 1%. And also you have to go even more slower if the patient is using lamotrigine. On chronic use, patients sometimes develop insomnia or aseptic meningitis. Topiramate. Topiramate is another antiepileptic medication that's commonly used here and has an absorption rate of about 80%, with the protein binding ranges between 15 to 40%. It has a minor metabolism, hepatic and renal, and decreases by the enzyme inducers and slightly by valproic acid, with the side effects that is mostly dose dependent. So what patients usually report is paresthesias, word finding difficulties, cognition impairment, and that's actually, you see these side effects when you go up with the doses, and sometimes even renal stones can be seen with these medications because it causes metabolic acidosis. Rare but serious side effects include hyperthermia and acute angle closure glaucoma. The next one is levetiracetam, which has an absorption rate of 100%. So you give the medication orally as you give it IV, and with a protein binding of 10%, metabolized only 30% of this medication is metabolized by hydrolysis, and no known side effects or interactions, or no known significant drug interactions. Works virtually on all types of epilepsy. Side effects, what we see with the levetiracetam is behavioral changes, depression, mood swings, and that's in about 10 to 15% of the time, and also can cause headache and vomiting. Oxcarbazepine is another common medication that we commonly use and has an absorption rate of 100% as well, and it binds to protein, and after it's metabolized to the active component, which is called monohydroxy derivative, or MHD, and interacts as the level may decrease a little bit by the enzyme inducers, and it decreases the lamotrigine and topiramate level, and may increase the phenytoin level. Okay. Side effects profile: only dizziness, drowsiness, and maybe rarely you see hyponatremia and skin rashes. Now, we talked about all the anti-epileptic, or most of the anti-epileptic medications that are being used in our country, and now we'll move forward and talk about epilepsy and how do you manage these patients when they come to you. So the definition of epilepsy have been changed recently, or the International League Against Epilepsy changed the definition to be more practical. So now when the patient presents with at least 2 unprovoked seizures or reflex seizures occurring more than 24 hours apart, that the patient has epilepsy. That's also old, or that's actually also the same as before. Patient with 2 or more unprovoked seizures 24 hours apart, that's the definition of epilepsy. What they added is 1 unprovoked seizure or reflex seizures, and probability of further seizures similar to the general recurrence risk at least 60% after 2 unprovoked seizures occurring over the next 10 years. So what does that mean? If you have a patient who has only 1 seizure, 1 unprovoked seizure, but the risk of having another seizure is more than 60% in the next 10 years, that's enough for definition, and you can call this patient as epileptic at that time. Also, the third thing is they added the diagnosis of epilepsy syndrome. So if the patient has an unknown epilepsy syndrome, so you don't wait for the second seizure because the patient has epilepsy by default. Then they added what's called resolved, or when the epilepsy is cured. So 2 conditions. First is the age-dependent epilepsy syndromes, but now are past the applicable age. For instance, benign Rolandic epilepsy, when it comes at age of 6 to 10 or so, and then at age of 30, the patient of seizures, no seizures, so that's called resolved, because it already passed the applicable age. And then the other condition, if the patient is seizure-free for at least 10 years, and off anti-seizure medications for at least 5 years as well. And in April 2015, the AAN, along with the American Epilepsy Society, they actually published the new guidelines in when do you start the anti-epileptic medications. So they talk about the risk of recurrence. So what they do, what do you do with the patient who presents with the first unprovoked seizures? So the evidence says that with one unprovoked seizure, the risk of recurrence in the first 2 years is about 20 to 45%. And then that risk goes up if the patient presents with strokes, trauma, or any brain insults, and the EEG abnormalities. And then in terms of management, they say that the clinician should advise patient that immediate anti-epileptic drug therapy compared to delay treatment pending a second seizure is likely to reduce the risk of seizure recurrence in the first 2 years. Okay, so if the patient presents with with unprovoked seizure, so we give them anti-epileptic medication, the risk of recurrence is low in the first 2 years. But also says that the patient, that the risk of recurrence after 3 years it's not going to change. So if you give the medication or not, after the first unprovoked seizures, the risk of recurrence after 3 years, it does not change based on the evidence we have. In this table, it's a simple way to calculate or estimate the risk of seizure recurrence after the first seizure, and that's, as we said, based on EEG as well as physical examination or etiology. So if you have a patient with a stroke or a patient with abnormal neurological examination or patient with EEG, and if the patient has partial seizures. So if the patient presents with none of them, so no partial seizures, it's generalized, and no EEG changes and no brain insults, normal physical examination, the recurrence is about 20%. But if all of them present, the recurrence is 77% or so. So it's between 20 to 77% based on these factors. How about prognosis? Or do we have a prognostic indicators for persistent seizures? Based on this study in New England Journal of Medicine 2000, the early signs of refractory epilepsy, including symptomatic or cryptogenic seizures, more than 20 seizures before starting anti-epileptic medications, and treatment failure from the lack of efficacy from the first step. So either the patient presents to you after 20 seizures, that's a bad prognosis, or if the patient fails to respond to first medications, or if the patient presents with symptomatic epilepsy, such as a brain insults, patient presenting with epilepsy or cryptogenic epilepsy. Now, we say that we have more than 25 anti-epileptic medications available for us. How about, and we talked about the type, the anti-epileptic medications and type of epilepsies. How about how do you choose the antiepileptic medication? So multiple factors, you have to keep them in your mind when you choose an antiepileptic medications. Is that appropriate for the type of epilepsy? And we talked about that. We covered it in the first few slides. Also, you have to consider cost. You have to consider prior allergies and side effects profile, comorbidities like weight, cognition, and psychiatric issues. Also, the metabolic status, like the patient has renal failure, hepatic failure, and the pharmacokinetics. Is this medication once daily taking, or is it twice daily, or 3 times daily? And then rapidly or slow titration. So can you give this medication really rapidly, or you have to go slowly? And then in women, we pay attention to pregnancy and contraception as well. So which antiepileptic medications? Almost no randomized double-blinded trials that look at this, comparing one antiepileptic medication to another. So it's all about expert's opinion, personal preference. The physician actually feels more comfortable with this medication or another. But based on availability in Saudi Arabia and other Arab countries, this is my preferred approach. For generalized epilepsy, I use either levetiracetam, lamotrigine, benzodiazepine, topiramate, valproic acid, and that's for generalized genetic epilepsy. And then for partial onset epilepsy, which is more common, I use carbamazepine, oxcarbazepine, levetiracetam, lamotrigine, topiramate, or phenytoin. And then we're not sure about the type, the common sense that you use medication that has a broad spectrum efficacy, like levetiracetam, lamotrigine, or topiramate. The only comparative studies we have is what's called SANAD, which was done in UK and published in 2007. And SANAD has 2 arms. One arm looked at the medications that works on partial onset seizures. The other arm that looks at the medication that work for generalized epilepsy. And for the first arm, they look at the other medications at that time compared to carbamazepine. Second arm, or for generalized epilepsy, they look at the other medications compared to valproate. This is large. In this study, they have large number of patients with a long periods follow-up, but it's unblinded study. So the result of this study says that in patients with partial epilepsy, lamotrigine may be more superior to carbamazepine and others. But if you look at the table, more or less all medications work with the same efficacy. And then for generalized epilepsy, they compared valproic acid to lamotrigine to topiramate. And in this type of epilepsy, they say valproate is still standard and should be superior in terms of efficacy to other medications in this type of epilepsy. So how about the monotherapy versus polytherapy? So we don't have an evidence that supports monotherapy versus polytherapy, but usually the first antiepileptic medication is the last one, and that's based on the same study we talked about previously. 50% of the patient, they respond to, about 50% of the patient, they respond to the first antiepileptic medications, and then additional 15% or so responds to the second antiepileptic medications. As we know, you refer to epilepsy centers for other options when patients fail 2 or more appropriately chosen antiepileptic medications. So what's appropriate doses as well? In this study also, it looks at the effectiveness of first antiepileptic medications. They looked at the sum of the antiepileptic medications. As you see in the table, that the dose ranges for most of the antiepileptic medication actually are medium. So for carbamazepine, although the maximum dose is 1200 milligram, the effective dose is about 600 or so. Valproate is the same case. The effective dose is 1 gram, although we can go up more than 2 grams. Lamotrigine is about 200 or so, and we can go more than that. So it tells you that if the patients were to respond, they respond from the beginning and they respond to a medium dose. How about the new versus the old antiepileptic medications? So based on the studies we have, they're more or less same efficacy. So the efficacy is about the same. But then much better side effects profile and less interactions with the new antiepileptic medications. The old antiepileptic medications are cheaper for sure, and then in general we usually start with the low and go slow, so to avoid side effects and CNS toxicity. So when you choose a medication, you start with the low dose, especially if you're not in a hurry. If the patient can wait, then you start with the low dose and go up slowly. Now, what's the best antiepileptic medications in terms, and if the patient has a liver failure, that is usually we would choose a medication that does not metabolize by liver, like levetiracetam, lacosamide, gabapentin, and pregabalin. And then in this special population in elderly, we pay attention because you even start slower and go, or start lower and go slower, because of the slow metabolism, as well as most of the elderly are already on other medications, and so we try to avoid the interactions. So in this study, when they pay attention to patients with to the elderly patient, and they randomize them to either lamotrigine and or carbamazepine, and the follow-up, they looked at the retention rate, so the percent of the patient that are still taking the medications, and they found that lamotrigine is superior to carbamazepine in that regard, but in terms of efficacy, they're about the same. Also, in this recent study, they looked at the patient with new onset focal epilepsy, elderly patient with a new onset focal epilepsy above age of 60, and which medication is preferable, and they compared levetiracetam, carbamazepine to lamotrigine. So they looked at the retention rate at the end of the study, how many percentage of these patients are still taking the same medications, and they found that the levetiracetam as well as lamotrigine, they have better retention rate compared to carbamazepine. Again, seizure freedom or efficacy is about the same. How about discontinuation of antiepileptic medication? When do you stop the antiepileptic medication? Which is, patients come every day to the clinic and asking about this. So you have to look at the good prognostic factors. Keep in mind the type of seizure. So if the patient has benign Rolandic epilepsy, that's actually a good prognosis or a good prognostic sign. Childhood absence epilepsy, idiopathic with few seizures, all these are good prognostic signs. And then seizure freedom. If the patient is seizure free for 2 to 5 years, of course the longer the better. A single type of seizure, normal examination, normal EEG. So all these are good prognostic factors, and at that time you can consider stopping the medications. On the other hand, the poor prognostic signs, including also the type of epilepsy. So if the patient has lesional epilepsy, like mesial temporal sclerosis, malformation of cortical development, or epileptic encephalopathy syndrome, such as Lennox-Gastaut and others, or JME or juvenile myoclonic epilepsy. Again, abnormal examination, abnormal EEG, they both actually are bad prognostic signs. And in general, the relapse rate for adults after you stop the antiepileptic medications, the pooled data says it's about 30 to 40%. Moving forward to what we called intractable or refractory epilepsy. So the definition of that is a failure to respond to 2 or more anti-epileptic medications using maximum tolerable doses. Now, and also well chosen. So now, if you have a patient who you give a medication that appropriately chosen for that type of seizure, and the patient failed the first medication, either you add another medication and the patient still fails, that means the patient has refractory epilepsy. Or even if you stop that medication and start another medication and the patient still not responding, that also includes refractory epilepsy. Again, you have to be careful with the definition because the medication have to be chosen appropriately. What options they have? They have epilepsy surgery as an option. The patient that's less likely to respond to anti-epileptic medications, of course, the earlier, the better outcome. So if the patient has temporal lobe epilepsy, the earlier and not responding to anti-epileptic medications, the earlier the surgery, the better the outcome. And the surgery decreases the sudden unexpected death in epilepsy and improves the quality of life. So what do we usually do for patients with intractable or refractory epilepsy? The typical workup is divided into invasive versus non-invasive studies. Non-invasive studies including admission to long-term monitoring with a continuous video EEG, also a neuroimaging, MRI of the brain is preferable, and PET scan or what we call also an ictal SPECT as well. So these are non-invasive studies. The invasive studies including the subdural evaluation or grids and depth electrodes. So you put electrodes inside the brain, either depth electrodes or subdural way, to look if this patient is candidate for surgery or not. This is a well-known, famous study talked about the outcome of temporal lobe epilepsy, a randomized controlled trial of surgery for temporal lobe epilepsy. A patient with intractable epilepsy, they looked at them when they add more medications compared to patients when they go to surgery. So the number needed to treat is 2, because about 58 or 60% of the patients that they become seizure-free when they do the surgery, compared to only 5 to 10%. So you need to treat 2 patients with surgery to get a good outcome. Okay, so that's a very good and strong evidence. And then not only that, also they looked in this study and they analyzed that the outcome of this surgery, and they looked at the quality as well as the life expectancy for patients with pharmacoresistant or intractable epilepsy. They looked only at the temporal lobe epilepsy. So the results are, if you compare the epilepsy surgery outcome compared to the medical management, which is the surgery we usually do is anterior medial temporal resection for a patient who is a 35-year-old, that would actually increase the survival by 5 years and increase quality adjusted life expectancy by 7.5 years. So compared to only adding medications, if you do the surgery, then the quality of life would improve as well as the life expectancy or even the survival. We say that it should be pursued for patients with intractable epilepsy, and the success of the epilepsy surgery depends on the seizure freedom and the post-operative deficit. So if you want to do surgery, you want to do it, and you're aiming for 2 things: the patient becomes seizure-free after the surgery, and with no neurological deficits. That's very important as well. Temporal lobe epilepsy surgery or anterior medial temporal lobe epilepsy surgery is the most common surgery with a good evidence and good outcome. Other therapies beside medications and surgical therapies, briefly, ketogenic diet, which is used mainly in pediatric age group. That's why we don't talk about it as adult neurologists and epileptologists. Mostly in symptomatic or multifocal epilepsies, and also for adults with intractable or refractory seizures. They are not candidate for epilepsy surgery and they're not responding to medical therapies. Then the other options include neuromodulators, and these are the devices that you implant, such as vagus nerve stimulations, responsive neurostimulations, and deep brain stimulation. And thank you.